All right. Welcome everyone. صباح الخير. برضو مساء النور for the people who الدنيا مسا بالنسبة لهم. Welcome to the sixth session of the Jazeera Rural Primary Care Echo Program. زي ما عودناكم, and as we do every time, we're just going to be going through a few welcoming, just a few minutes of welcoming and some session reminders, and then we're going to be starting our didactic presentation with Dr. Muna Shakir, and then we'll have our case-based discussion as always, and then maybe a few minutes if we have time for a general Q&A. For our housekeeping reminders, discussion makes this work best. إذا في أي زول عنده سؤال في أي لحظة, please feel free. You can share it in the chat. You can add your insights portal. You can also raise your hand and ask a question by mic if you would like to. We love to see your faces, so please open your cameras if your network allows that. Stay unmuted unless you are speaking. And these sessions are, as always, recorded, and you will find the link to the recording in the recap email that we sent after the session, and the presentation is already on the iEcho platform. Before we start, I'd also like to thank our participants in today's session, the University of Nebraska Medical Center and the Global Echo team and Echo India team for their continuous support, the faculty at the Jazeera University Faculty of Medicine, the students, and our other guests joining from outside the university. Thank you so much for joining us. ده البوستر اللي احنا بنعمله لكل سيشن, هتلقوه ملصق في كم حته كده في الجامعه كتذكير يعني للسيشنز. البوستر حقنا للسيشن دائما بيكون فيه السبجكت ماتر اكسبرت حقنا والكيس بريزنتر and the title and the QR code القاعد بيتحت دي. You could always use it to sign up للiEcho platform عشان تخشوا للسيشنز ان شاء الله. All right, without further ado, ممكن نبدأ didactic presentation حقتنا مع دكتورة منى شاكر. Dr. Muna, if you would like to introduce yourself, and the floor is yours.
Thank you, Mustafa. Thank you for coordinating this session, and thanks to Project Echo India and the representative today. I hope that you can hear me clearly in the room. Yeah, good. Thumbs up if you can hear me okay in the audience. Yeah. Great, fantastic, lovely. طيب, السلام عليكم ورحمة الله وبركاته. My name is Muna Shakir Muhammad. I'm a diabetologist and endocrinologist currently practicing in the UK. I'm also a graduate of Jazeera University, and I work with medical students. I'm a supervisor of Students' University of Glasgow School of Medicine, and I also work part-time with the University of Dundee on diabetes technology-related project. So I'm talking today about diabetes prevention, or especially talking about the category of pre-diabetes and how do we prevent its progression to type 2 diabetes. Next slide, please. So the learning objectives that I set for today is first is to define what is pre-diabetes and its different diagnostic criteria, to understand the significance of pre-diabetes and why do we need to tackle it, to understand the risk factors and implications of pre-diabetes, how to prevent type 2 diabetes at population level, and I'll focus on a program called Let's Prevent Diabetes. And then we'll speak about prevention of type 2 diabetes in high-risk individuals, and Dr. Farah will present a case later. So while talking, we'll try to bring everything back home, talking about your placement in rural residency and how do you apply the knowledge that you learned today to your current program. So what is pre-diabetes? Pre-diabetes is an intermediate state of hyperglycemia, so high sugar levels basically, with the parameters above normal but below the diabetes threshold. So high sugar levels, not up to the level of diabetes, but still high above normal level. And there's different diagnostic criteria. So in the diabetes community, we're a little bit fussy, and we don't often agree with each other as individuals and as institutions, but we're a great community. So consider diabetes as a specialty, but also be aware of the variable kind of variation in presentations and criteria, diagnostic criteria, and all the kind of philosophical arguments about various things. Okay, so pre-diabetes basically is high sugar levels, not up to the diabetes level. And so there's different professional organizations that has defined pre-diabetes. And no matter how disagree on the numbers, pre-diabetes remain a state of high risk for developing type 2 diabetes with a yearly conversion rate of 5 to 10%. So that's why it's important that we prevent, because there's a very high yearly conversion rate from pre-diabetes to diabetes. Next slide, please. So, I'm going to discuss about 3 criteria. 2 of them are pretty similar, but so the units that we'll use for glucose, I'll try to use 2 different units, the most commonly ones that we use, and I'll use 2 different units for HbA1c, where you'll find that the unit that you use in Sudan may be different from what we use here in the UK, but essentially you can do a simple conversion. You need to double check for the purpose of your exam, but I think in Sudan, most people use milligram per deciliter. So the criteria to diagnose pre-diabetes has 3 elements. If a person or an individual have impaired glucose tolerance or IFG. The second criteria is you have the individual has impaired glucose tolerance, impaired fasting, impaired glucose tolerance, or HbA1c, glycated hemoglobin, above the normal range but below the threshold for diabetes. So these are the kind of the 3 broad headlines. So impaired fasting, essentially above 100 milligram but below 126. So if the sugar, a person is fasting, and fasting by definition is 8 hours. So if someone's fasted less than 8 hours, that does not count as a fasting blood plasma glucose. So once it get above 100, then you're in trouble, or the person who's with the high glucose level is at risk. The ADA criteria is 100 to 125. WHO criteria is a little bit higher, is 110 to 125. So the thresholds are a little bit higher. And we usually, the WHO takes cutoffs for various diagnosis purposes for different conditions, taking in account the kind of the global burden of disease. And how is that going to affect the systems? So, for example, if the WHO lowers the criteria, there'll be few million people around the world with the category, and that has lots of implications on health systems and at individual levels as well. So, 100 is the number to remember. So 100 is where the trouble starts, whether it's pre-diabetes if you're up to 126, or type 2 diabetes if it's above that with symptoms. Okay, so 110 for the WHO criteria, 100 for the ADA criteria, and the NICE criteria will come in the next slide. Impaired glucose tolerance, where the 2-hour plasma glucose during a 75 gram oral glucose tolerance test is between 140 to 199. The impaired glucose tolerance is universally accepted. Nobody argues about that part. So the numbers are similar, 7.8 to 11 millimoles. Above that is diabetes if a person has symptoms. So there's no argument about impaired glucose tolerance. So fasting 100 or 110 to just below the cutoff for diabetes. Impaired glucose tolerance 140 to 199, so just below the 200 where you diagnose diabetes. And the WHO criteria also implies that the fasting is less than 7, which is below the threshold for diabetes. So impaired fasting, impaired glucose tolerance, and HbA1c. Now the WHO does not use A1c, but in ADA, the threshold is 39 to 48. And that's in millimole per mole. I think in Sudan, we generally tend to use the percentage. And this is gradually being phased out. So hopefully by the time you graduate and start practicing, very few people will still use the percentage, but for this presentation purposes, it's 5.7 to less than 6.5%. That is ADA criteria. So if someone was found to have prediabetes, then the test should be repeated annually, because you really need to see that conversion rate of 5 to 10%. So once the person is diagnosed with prediabetes, unless they've managed successfully to reverse it, then the test should be repeated annually to double check that they've not developed type 2 diabetes. Next slide, please. Okay, so this table just summarizes. So I've used two tables from diabetesonthenet.com. So this table shows the 3 different diagnostic criteria. As I said earlier, there's WHO criteria, there's American Diabetes Association criteria, ADA, and there is NICE criteria, which is the National Institute for Health and Care Excellence in the UK. So our numbers, what my daily practice, I use NICE criteria. Obviously, depends on where you are and then you kind of follow the guidance accordingly. The WHO, as I said, doesn't use HbA1c. HbA1c has got its issues. It's not readily available. Lots of interference with the test itself. It's a different topic, but the criteria for NICE is a little bit higher than the American Diabetes Association in terms of cutoffs. So the Americans use lower numbers to diagnose diabetes, whether it's HbA1c or it's a fasting. When it comes to the 2-hour OGTT, everybody says the same thing. So that's one thing that everybody agrees on, that the 2-hour oral glucose tolerance test result should be between 7.8 to 11 to label an individual as having pre-diabetes. And then the fasting, again, the Americans go for the tighter numbers, so 5.6 to 6.9 millimoles, as I said earlier, with the WHO and NICE going for the higher cutoffs. Next slide, please. Okay, so who's right? So the WHO has had a thorough evaluation of different cutoffs, and it's found that if you use the lower cutoff people who are in the range of 5.6 to 6 millimoles per mole. And I'm sorry, I keep reverting to the 6 millimole per mole because this is my practice for the last 12 years. So I hope that doesn't create any confusion. But using this cutoff has the people in that range have half the risk of developing diabetes as in the higher range, which means that if you are on the higher end, you're more likely to develop type 2 diabetes. But these people are still at risk, but they have half the risk. So the American Diabetes Association chose to use the lower cutoff to include everybody, while the the WHO and NICE opted for the highest risk individual for prediabetes. Next slide, please. So what's the fuss about? What's at stake? And why do we talk about it all the time? Because 30% of people diagnosed with prediabetes will develop type 2 diabetes quite soon, so within 6 years. And remember, when it comes to diagnosing diabetes or prediabetes, you might see the person at 5-year point where you have interaction with them. So you may already have lost 5 years to diabetes, and this individual may go on to develop type 2 diabetes next year. So that's a big percentage. That's like a third of the whole population who with prediabetes can convert very quickly to type 2. And then the other point is that 5 and 10% of all people diagnosed with prediabetes will go on to develop type 2 diabetes every year. So I mentioned this as a conversion rate in my earlier slides. But the International Diabetes Federation has predicted that the prevalence of prediabetes globally could reach as high as 531.6 million people by 2045. So it's going to be a huge burden. Next slide, please. So what are the risk factors? Risk factors include obesity, age, physical inactivity, family history, ethnicity, deprivation, mental illness, in women, polycystic ovarian syndrome, things like previous pregnancy-induced diabetes, and also some medications. So can I just go to the audience now and ask for, does anybody know a medication that can put the risk of pre-diabetes up? Can anybody volunteer just a single medication that can increase the risk of diabetes, pre-diabetes? Mustafa?
Steroids. Steroids can do that.
Yes. So yes, so steroids is one of the medication that can increase the risk of diabetes. And when someone takes steroids, then usually it's not the fasting. It's the they get hyperglycemia later in the day. So if you know that someone is at risk and they take steroids, and perfect, Fatima, thank you for answering. So when they take steroids and they can't do 2 blood tests, they can't have an oral glucose tolerance test, then you can do a sugar test after a meal, the evening meal, or before the evening meal, later in the day. So steroid hyperglycemia classically will not cause fasting, impaired fasting. It will cause the sugar to be rising later. So when you're thinking at individual level, and we'll talk about personalized care later, understanding those risk factors and how they will manifest as impaired fasting or impaired glucose tolerance, hydrochlorothiazide also can cause that. Thank you, Nahid. So yeah, so when you're thinking, and also in limited resource setting like Sudan, we also have to take into account, like if I want to choose one test, which one do I go for? These are the kind of the main risk factors for developing diabetes. And there's lots of new medications that can cause diabetes and hyperglycemia as well. So that's another topic. Next slide, please. Okay, so just a quick kind of summary of the clinical effects of pre-diabetes. So it's progression to type 2 diabetes, which, almost all of us know that for sure, but it can also increase the risk of complications, including, so these are complications, even if the person does not go on to develop the full-blown type 2 diabetes. So they're not type 2 diabetes yet, but yet they can develop diabetes-related complication. So chronic kidney disease, neuropathy, retinopathy, and if you get people who have pre-diabetes, 100 people, and you look at their retinas, you'll find that about 8% have established retinopathy already before having the full-blown big picture of diagnosed diabetes. Does everyone know why did they choose an HbA1c cutoff to diagnose diabetes? Like, why do we say 48 millimole per mole? Does anybody know? Like, why do these cutoffs were made to diagnose diabetes? The fasting of 7.1 or any other criteria? $50 for correct answer. Obviously not the postgraduate. So you have to be undergraduate. Postgrads are not allowed to answer.
That's a little biased, but okay. Shabab.
Okay, so I can't see any hands up. Okay, so the cutoffs for diagnosing diabetes. Why did we choose that A1C level? Is because that they found that retinopathy starts at that cutoff. So the 48 millimoles per mole for diagnosing diabetes, the cutoff of A1C was chosen because that's where retinopathy starts in the majority of people. But in pre-diabetes, in some people, it starts a lot earlier. So it's a continuum. So I like you to think of diabetes as a continuum. It's not just one condition where complications happen at one point. No, it's a kind of a spectrum of glycemia where at the very beginning, people start with, pre-diabetes, then they go on gradually into beta cell failure, where they developed type 2 diabetes. Then at the end of the spectrum, they have complete beta cell failure, where they have no insulin reserve whatsoever. So as I said, complications of diabetes can happen from pre-diabetes per se. So chronic kidney disease, neuropathy, retinopathy, coronary artery disease, and in some studies, stroke risk can be increased by as much as 21%. And remember, these individuals don't just have diabetes most of the time. They have dyslipidemia sometimes they will have hypertension, so kind of other metabolic risk factors. And if you add smoking into the spectrum, that's just a disaster in waiting. Okay, next slide, please. So there's lots of studies, lots of literature. You get different percentages. I opted to choose this range of a percentage of about 25 to 40% as kind of average. But different studies show different, depending on the intervention, show different levels of prevention, some as high as 70%, some more kind of about 58%. But there's a very good article in the Lancet, it's published in September this year, kind of gives a very good summary of overall the diabetes prevention programs and their lifestyle modifications and how they kind of prevent type 2 diabetes in lower and middle income countries. So it's a recommended read. Next slide, please. Okay, so here we go. So this is a quick example of which program, what the kind of the form of blood test they've done, what treatment they offered, and how much risk reduction. So the diabetes prevention program is the program if you go on to do medicines, that medical statistics, research, primary care, any kind of public health. You'll hear about US diabetes prevention program a lot because it's a kind of a program spanning 44 years focusing on diabetes prevention. It's one of the most fantastic pieces of research in the human history. I'm slightly biased, but that's what I think. So diabetes prevention program show diet and exercise can cause relative risk reduction by about 58%, up to 58%. And similar result was shown in the Finnish diabetes prevention study. Again, Scandinavian countries have got very good registries, and they are a source of very good population level information, and they have very good, well-structured studies. So about 58% really was found to be kind of the risk reduction from diet and exercise alone. There were attempts made to add metformin for prevention, and these didn't show that metformin was superior. And but it's an option at individual level. But as a kind of on a population level, you really can't give metformin in the tap water. So it does reduce the risk, but not superior to diet and lifestyle. And sometimes giving that message that I can give you a pill and you'll be okay is not a good start, because obviously diabetes is a disease that kind of continues to progress. Type 2 diabetes and pre-diabetes continues to progress to type 2 diabetes. So sometimes giving the tablets, medication is the wrong way. And what you need to focus on is lifestyle modifications. Next slide, please. So what are these interventions? The lifestyle intervention include dietary modification, diet changes, increased physical activity, and psychological intervention to achieve behavioral modification leading to prevention of prediabetes. Now, the number to remember when it comes to lifestyle modification and prediabetes is 7%. If someone loses 7% of body weight, so someone whose weight is 100 loses about 7 kilos, they can essentially reverse prediabetes in most cases, obviously, provided that there's no continuous kind of other factors that contribute to weight gain or other states of hyperglycemia. So the number to remember is 7%. So Pre-diabetes, you want to reverse it, aim for 7%. And sometimes that's better than telling the patient, go lose weight and, you know, walk for 3 kilometers every day. So when you give a patient a target, that works better. And just by the by, because I'm talking about pre-diabetes, in diabetes, the number is 10%. So if someone has type 2 diabetes and their early years of diagnosis, that's from 0 to 5 years, and in some studies showed up to 7 years, they can actually go into remission. And the number there is 10% of body weight. And for most individuals is 10 kilograms. So, 10 kilograms, yeah, is the number. So pre-diabetes, 7%, type 2 diabetes is 10%. So when you talk to your patients, that's the figure to quote, that's the percentage. Maybe not in percentage, but in kilograms, you just can work out from their body mass index and their weight. Next slide, please.
Sorry, before we do move to the next slide, Dr. Mona, I'd like to ask about the dietary modification. Is there a certain type of diet that's best and easiest for patients to go through?
Yes, so that will come in the next few slides. I kind of felt that the question will be coming, so I put that in the next few slides. Thanks, Mustafa. So yeah, so before I go in that part, if that's okay, I'll just speak at a population level first. So when you go and visit, you know, القرى تحت الجزيرة لما تمشوا الإقامة الريفية أو for the whole state، يعني الناس اللي بتخطط على مستوى الولاية كلها، or for the whole country. لو انت بعد ذاك بقيت انت مسؤول في وزارة الصحة وصلحت لنا السجن والرماد الحاجات اللي بتحصل في السودان، أو بقيتي مسؤولة طبعا all for women empowerment، أو لو بقيت مسؤول أو مسؤولة عن the whole region، MENA region, if you're working for the WHO and you were assigned to work at population level and sort things out. So how do we prevent at that level? So obviously, I'm not stepping on any toes of my colleagues in public health, but I'm just trying to summarize from our perspective on what we do locally. So I work in a community where there is high risk of diabetes and diabetes-related complications. And so what I'm going to tell you here is not just theory, but also a program that we implement locally. And what I'm hoping that you will take from the presentation today is think about how you can apply it at the micro level, at the macro level, and who knows who will be who in the future. You might, be able to take what you learn from your residency and generally all the kind of the curriculum in Jazeera University forward, and will help you in your future career, inshallah ta'ala. So when we talk about population level, then we need to implement a specific weight management pathway for those at high risk. And obviously, when you think about population level intervention, you just don't separate pre-diabetes and diabetes. Usually, your intervention is tackled for both. But for the purpose of this session, we're focusing on pre-diabetes only. So you focus on prevention, early intervention, and also specialist interventions. And there's usually requirement for multidisciplinary and multi-agency teams to work together with the public to deliver the kind of fully supported approach. So things like group education, coaching, cooking classes, community activities, دافوري في الحلة, football matches, wider community. أحيانا في دول بتدي financial incentives for people who participate. So you really need to have people on board at all levels to have very effective approach in lifestyle modification. But we'll talk later about what you see when you see, the family that you're visiting at home as part of your community medicine program, or the patient that you will see later, inshallah ta'ala, when you graduate and you're trying to educate them. Next, please. So this is how the framework that we work within. Obviously, just to clarify that I do not, my team delivers this. my wider team delivers this, but I don't work in prevention side because I work with slightly more complex type 2 diabetes. But you know, it's part of and parcel of the wider team mission. So we work on, so if you see the first column is prevention. So prevention of the whole population, children, families. What you need to deliver is core messages. So when you go and visit, يعني لما تمشوا القرى ما كل زول يتكلم بطريقته، يعني ما كل زول يقوم يقول والله ما تاكلوا عيش كثير، والله مثلا يعني تريضوا كده، يعني لا، لازم انتوا تكونوا محددين اذا انت حتعمل على population no matter how big or small is the population. طالما انه عدد كبير من الناس انتوا لازم تقعدوا قبل ما تقدموا الهيلث مسج بتاعتكم and you decide what are your core messages. You aim to make the people aware of the risk, so what puts them at risk, and you kind of try and make it more like a health campaign rather than I deliver it in certain way, Dr. Mujtaba delivers in a different way, Dr. Farah delivers in a third way, so you have to be kind of consistent. And then the next level is early detection. So when you visit the family, for example, then you find out who is at risk. So in this wider framework, obviously it's for the whole population. So, everyone can do a risk assessment, and this is kind of being promoted. So everyone knows to have the risk assessment, how to have the questionnaire online. The questionnaires are found in pharmacies that everybody can go into pharmacy and pick up one, and they can help them, assist them in filling it out. There's also risk class stratification from professionals in primary care, for example, and everything should be accessible and available for the wider community. And then there is early intervention. So the intervention is, that's the third column from the left. So those at high risk. So you go to the family or you go to the village and you find out that there's a certain group of people or a few individuals or one of the family members with a high risk. So again, you need the risk stratification. You need to make sure that you refer for early diagnosis, with again at individual level or at the village level or at the whole population level, and you target the support to those at high risk because they are not like everybody else. They're more likely to develop prediabetes and diabetes type 2 diabetes. So that's that. So early intervention, and then there's early intervention for those at risk, and there is early intervention as soon as the people develop type 2 diabetes. I'm just talking about this because it's a continuum, is that people get, diagnosed early, we teach them early, we specify, so we refer them to specialists and try to reverse type 2 diabetes because type 2 diabetes can go into remission within the first 5 to 7 years. So this is the overall, this is how you do it overall. So when you go out, reaching out to people in the village, think about how do you prevent at the wider level. So if you organize, for example, an event in the village, how do you talk to people? What are your core messages? If you're doing, if you have a, sometimes you take a lab facility, like quick glucose checks, things like that. Although to be able to diagnose prediabetes, you need a lab raw to read glucose. You really can't do it with a finger prick. And then if you find a group out of the whole population of the village that are high risk, then you need to target your intervention to them and target your support to them. So you can do small focus groups to talk about it. Lovely. Next slide, please. Now, so Let's Prevent Diabetes is a program that we deliver locally as a team. It's a community-based primary prevention program for type 2 diabetes, and it encompasses everything. So identification, lifestyle intervention, and the community services. Can everybody else hear? Because there's a message that someone cannot hear the presentation. Everyone can hear okay?
Yeah, I think it's good on my side. They might need to reconnect the audio.
Lovely. Good. I hope you don't miss much, but do you record the presentation for? Yes, it can be shared later if you miss anything. Great, thank you. So next slide, please. So this is a Let's Prevent program. So what we do is we get people as soon as are they identified as high risk for diabetes or having pre-diabetes. The identification could be from medical students just like yourselves. It could be from pharmacists, allied healthcare professionals, from doctors in primary care, from everywhere. And then we group them into 8 to 10 people in small groups. We choose a venue, a suitable venue for primary care, usually in the health center. And we provide them with supporting material. We usually have 2 educators, so 2 trained healthcare professionals who are aware of the Let's Prevent Diabetes curriculum and can deliver the education. So they deliver, there's 2 formats. There's 1 day and there is 2 half-day sessions. And the patient generally, so we don't like the term patients, but people with pre-diabetes receive about 6 hours of structured education with a curriculum that's quality assured, revised, and the content and the process is kind of very clear, and there's clear guidance and principles kind of guiding the whole approach. And prevention of diabetes is one of the main strategies of the healthcare locally. Next, please. Okay, so that's again on Let's Prevent Diabetes. So keep this in mind. Then when you talk to people, you need to be 50% focused on knowledge and perceptions. يعني احنا ما نمشي طوالي ونقوم نقول للناس ايوه اكلكم ده ما كويس, don't eat this, don't eat that. هيقول لك ايوه كويس يا دكتور, كويس يا دكتوره, كويس يا بنتي, وبعد شويه تطلع بالباب وينسوا كلامكم وما ما يعني ما حيكونوا مهتمين يعني بالموضوع وما حيسمعوا. فأول حاجة زول يستكشف الناس فهم شنو في الموضوع. يعني you need to understand your target audience. What are their perceptions? What do they know? What's their prefixed ideas? في lots of myths, في lots of kind of beliefs. You need to understand the community that you're talking to so you can target or tailor the health message to them. Okay, so so you need to first understand their perception, then pass on the knowledge. It's a knowledge about, food types, what sort of physical activity that they can do, what is diabetes, what's pre-diabetes. And so usually the session starts with housekeeping. If you see the top of the pie chart, and then a patient will tell his or her story. Then you speak what is pre-diabetes, what's glucose. We speak about food choices, physical activity, and then some reflections. Then you deliver about 50%, about lifestyle behavior. What do they need to do? What's the action planning and things like that? So you talk about risk factors and complications. You speak about food choices. And when you speak about food choices, make sure that you're tailoring this to what's available locally. Because what we learn in medical textbook is not necessarily our local diet. And so you really need to understand the local diet. Because again, it might be slightly different from different places. So you need to really understand when you offer such a program to, when you talk to the family or when you talk at the village level, you really need to focus on what do they eat actually, what's good about it. Maybe focus on what's good about it first before you give suggestions for changes that may have preventative effects. And then the advice is generally to develop a personal plan. So if you're seeing an individual, you just don't give them a blanket diet. eat this, don't eat that, 5 portions of vegetables and fruits a day, blah, 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 go home. No, it needs to be a personal plan. And then you also plan future care. So what happens next? Like, okay, I attended this program. I'm very happy with the advice that I received. What do I do next? So if someone has prediabetes, then they need to have annual checks for prediabetes. If they go through another program that, you can be referred onwards from this program for another program to help them lose weight. So after you finish the session, you need to signpost those individuals to different levels of resources. عندكم فيسبوك جروب بتاعت ما عارفه اسمه شنو الرياضي السوداني، عندكم الكوره بيلعبوها في الحله، عندكم مثلا جروب بتاعت سيدات بتاعت رياضه، يعني حسب الكوميونتي اللي انت موجود فيه. You really tailor the message, but you really have to give people future care plan. You can't just see them and give the message and say مع السلامة, that's me. Good. So next slide, please. Sorry, there we go. So this is the curriculum that we use, and we have a curriculum for educators and for the patient and resources and various things, but really it doesn't have to be fancy. So when you are delivering the health message, sometimes the simple, concise messages really work. However, structured education is really core to delivering, health promotion messages. So if possible, then ideally you should deliver it with a full curriculum. Next, please. So how are we for time, Mujtaba? Good, yeah. Okay, so symptoms. So when you see someone with prediabetes, this is hopefully discussion is going to be about that. So symptoms of diabetes, if they have any, because they might be or over the prediabetes phase, you speak about nutrition history. So in our specialty, we really find everything about the patient sitting in front of you. The history taking that you take in Jazeera University is the core of your medical practice, no matter what you do. بيزرزروكم في الراوند، بشكلوكم وبهدلوكم كده، لكن is really a life skill. It's a skill for the rest of your life. ما يستحملوا ويطردوكم وكل الحاجات دي، لكن يعني hopefully حقوق الإنسان اتحسنت في الجامعة from the time that I left، لكن it might not be the case as you can see from facial expressions. فالمهم يا جماعة خلاص يعني hopefully in the future things will change، لكن I think what you learn is a core skill, is an absolute core skill for your future no matter what you do. حتى لو طلعت من المخزن كله عملت حاجة تانية، the history taking is a skill. How to ask questions, how to get to the bottom of the problem is a key skill no matter what you do in life. So when you ask about nutrition, ما تسأل بتاكل شنو، بتفطر شنو، بتتغدى شنو، بتتعشى شنو. No. تصحى من الصباح دعكت عينك بتعمل شنو. الزول بيقول لك اليوم كله throughout the day what happens. لأنه مرات مثلا تقول لك بتفطر شنو، يقول لك أيوة بفطر مثلا فول وبيض. إحنا أكلنا السوداني is really good. So يعني if our original food أصلا أكلنا الأصلي is really good، يعني فيه big chunk of protein، few low grain carbs وكلها. But modernization and urbanization has moved us into processed food and processed diets. So بتقول للزول اوكي صحينا الصباح اي فطرت فول وبيض، لا لكن انت بتكون you missed القراصه بالتمر اللي اكلها مع الشاي الصباح مثلا. فانت ما بتسال الزول انت بتعمل شنو، انت you follow the whole day علشان to get every single activity of the day وبتعرف the nutritional aspect of that particular activity. بنمشي لجارتنا بنشرب قهوة، طيب القهوة مع بلح. So you really يعني سؤال نكير اللي بيقولوا عليه ده you really have to do that for your history. And the more you do, the more you get out. And to get a diagnosis in a clinical exam, in a patient consultation, in your future, أي حاجة, it depends on the history. So nutritional history is very important, and the weight history is very important as well. يعني زدت كم كيلو في كم سنة، وزنك زاد نزل يعني بالتفاصيل. يعني في ناس ما they don't check their weight regularly which is fine. ممكن تسأل من الدريس سايز أو الجلابية، غيرت مقاس البنطلون، القمصان كده. يعني في طرق مختلفة تعرف بها الحاجة دي. You assess physical activity. I'll speak later about the physical activity recommendations and other cardiovascular factors that, you know, family history of sudden death, dyslipidemia, etc. History of complications, because they present with pre-diabetes, they may already have neuropathy, so you have to figure that out. Things that's unique to women, pregnancy, not so unique anymore, but you know, women as in pregnancy, PCOS, and large for gestational age babies. Family history, again, family history is really important, and Q-risk score. If you have mobile phones, can you Google Q-risk score, please? And keep it there on your screen. We'll talk about it later and try to use it in our case. So Q-risk score calculator. So this is what we generally use. It's different calculators, different qualities. And I suppose now in this information age, you just be very careful what you use, because I tried different calculators last night. I found ones that are really probably made by an amateur who's in about 14 years old. So just be careful what you use. Make sure when you use information online that you use it from reliable sources. So Q-risk score, and then we'll talk about it later. Next slide, please. Okay, so this slide is about prevention and management. So you give the individuals personalized advice regarding diet and physical activity. That's Mujtaba's question. So which diet? And I think I have further slides about this, but generally, you ask the person about their preferences. I can tell someone, for example, to use I can't tell them, for example, to use a keto diet or low carb diet or high fiber diet or whatever, while they have intolerance. زول يقول لك أنا عندي مصران الحاجة الفلانية دي ما بتنفع معي. زول يقول لك والله أنا عندي مثلا أول ما يعني بيجي لما أشم ريحة مثلا الأكل الفلاني بطني بتطم. بتلقى الحاجة دي more in pregnancy as well. The food cravings, the food aversions are very common in pregnancy as well. So you really have to take into perspective what is the personal preference at the individual level, but also at the local diet. When you ask someone to change their physical activity level, be aware of their abilities first. عشان كده بنرجع للهيستوري تاني. انت بتقدر تمشي كم؟ لو الناس بتسبح قدر كيف؟ ممكن اقول لك انا ما بقدر امشي لغايه خشم الباب. So how are you going to lose weight? ما ممكن تيجي تقول له امشي لك 3 كيلو وهو خشم الباب ما بيقدر يمشي. ف you have to take this. So unless you take a good history, you really can't prevent anything, because you need to understand whether at individual level or understanding your population at population level, how can you give the advice. You take into account medications, you take into account other comorbidities. ما ممكن تقول لي زول يقول لك أنا كويس وبسبح مثلا 3 كيلو 4 كيلو بسوق العجلة بمشي من هنا لغاية الحلة الثانية مسافة 10 كيلو برجليني. تقوم تقول له خلاص اعمل الحاجة دي وهو يكون عنده chest pain. He should be resting at home. If we keep in mind, these factors as well, medications, cultural beliefs, etc. Now, we spoke that diets and lifestyle are the best. الغصب ده ما بينفع. الغصب doesn't work. المشكلة. فnice. It says you can prescribe metformin or orlistat if diet and lifestyle interventions fail. And you can do this in urban communities. لو أنت شغال في الخرطوم ولا في دبي ولا في حتة ثانية. Again, sometimes if people are really struggling to feed their families, you really can't prescribe a medication at pre-diabetes stage. You might want to save that up and focus on the intervention first. But at a kind of at the population, at the individual level, at the population level, you really can't give metformin in tap water. Sometimes some people think we should, but no. So you give it at individual levels if you think the risk is really high and they tried really hard, then you can prescribe medications for kind of to prevent the situation getting worse. Next, please. So that's your question there, Dr. Mirtaba. So which diet? The one that achieves and maintains a weight loss target of the 7% if you have the diabetes, pre-diabetes, or the 10% if it's type 2 diabetes. So generally the plan is to 50% vegetables. So طبعا الخواجات بياكلوا في صحن واحد، يعني بيحطوا الاكل وكل زول بيغلب بيشيل في صحنه. فالادفايس دي صعب احيانا نقولها لناسنا احنا اللي هم الناس كلها بتاكل في الصينيه مع بعض. المشكله اكل الصواني ده هو اللي بيخلي الناس عندنا انهم ما بيقدروا يعرفوا البورشن كنترول حقهم. لكن في ناس في السودان I've seen lots of people with diabetes are really careful about what they eat and they will take a plate and plate up and eat from their plate. ودي الحاجة بتخليك تعرف إنك أكلت كم عيشة، أكلت لك زي نص الضلعة ولا اديت الناس فرصة معاك كده يعني. you really want to keep an eye on the portions. So ideally you plate up and you have 50% vegetables in your plate, or obviously the person that you're advising. 50% whole grain carbs. العيش الأبيض ده أسوأ حاجة حصلت في تاريخ البشرية. العيش الأبيض is really harmful. It causes diabetes, causes lots of other problems as well. Obviously these factors increase risk of malignancies and dementias and strokes and all the full baggage that comes with it. So whole grain carbs. العيش لازم يكون فيه حبوب وردة وكده، يكون كده مناعي. الزول اللي بيتعود على seeded bread، بيتعود على الهول grains في الأكل، بيشوف العيش الأبيض زي القطن، زي كده بتاكل لك قطن وول. لكن انت محتاج لك 3 أسابيع انك تلتزم او انك تلتزمي بانك تاكل الهول جرين بريد علشان الطعم بتاعه يبقى لك it's your habit. 3 weeks usually is at least the time that takes for you to change a habit. So whole grain meal, whole grain carbs, and 25% lean protein. يعني إحنا مثلا أكلنا الفول والبيض والحاجات يعني اللي بناكلها في أكلنا الطعمية، رغم إنها فيها بتكون معظم الأحيان فرايد وفيها extra fat، لكن عموما إحنا our food is rich in protein. لو الناس بتستطيع، لو الفاميلي، طبعا الزول لما يقدم الهيلث مسج بيكون خاطي في باله استطاعة أهل البيت اللي هو بيديهم. يعني ما ممكن نمشي لأسرة فقيرة وهم ما قادرين ياكلوا ويشربوا نقول لهم أكلوا لين ميت ولحمة بدون دهون ودجاج وسمك وكده. فأنت when you provide the advice you really have to tailor it to your audience. But generally the diet is a diet that avoids high refined sugars. السكر اللي بنريده في السودان السكر الأبيض، الناس الكلها دي يعني بيقلب الحكومات مرات. We need to avoid it. البروسيس فود، احنا طبعا مشكلتنا في السودان يعني بالعكس حياتنا الأصلية حقت أهلنا، حقت الزراعة والأكل الأورجانيك، وحس الخوايات هم بيحاولوا إنه يسعوا للحياة دي. يعني أزول كل ما يغنى في in the West يعني they try to go back to our life في السودان 50-60 years ago لما كنا بنزرع الأكل، ما في سمادات، ما في سماد في الأكل، ما في حاجة تجي من علبة تتفتح تتاكل، ما في processed food. السكر هو السكر الطبيعي، لو في مثلا عسل، لو في فروت، لو كده طبعا سكر الفواكه هو الأفضل. الدايت طبعا ما في زول تقدر تقول له الدايت الفلانية بلانك. طبعا في الدايابيتس it's a science obviously, diets are a science. لكن في العادة أنت بتقوم تقول للزول شنو يعني الحياة المحتاج إنه يطلعها من الأكل، ومن الهيستوري بتاعك بتكون تعرف كله مريض أو كله person with diabetes مشاكله شنو؟ مشاكلنا في السودان الطحنية، السكر، العيش الأبيض، ما بعرف الزلابيا، يعني في حاجات معينة كده سهل شديد إنه زول to identify as problems. وإحنا في عموما in diabetes we don't say never eat this or never eat that. مهم شديد إنه you tailor your message، تقول يعني لما يكون عندكم مثلا كرامة في الحلة is okay تاخذ لك حاجة مثلا حلوة، لكن تتحكم في البورشن سايز. لما تكون ماشي عرس ويدوك صحن الكوكتيل السمح داك حق السودان، تقوم ممكن just select الحاجة اللي انت ممكن ما تأثر على ال overall progress بتاعك بتاع ال prevention of prediabetes. But it has to any diet that you prescribe has to create a caloric deficit، يعني يكون أقل من ال requirement بتاعت الكالوريز حقت 24 اور، هي بتختلف بين النساء والرجال، بحيث انه الزول ده يستخدم الدهون المخزونه عشان يحرق بها وينزل للويت الصحيح. It's a whole science. I can't claim that I can teach dietetics, but these are the general guidance. كل زول تشوفه تبي تقوم بتاخذ الهيستوري بتاعه وبتحدد له الحاجات وبتديه الجايدنس انه الفيجيتابلز كم، الفروت كم. في big disagreement about diets، لكن generally lots of the new diets for type 2 diabetes، في a lot of research in type 2 diabetes that run pre-diabetes بيحدد عدد الكالوريز 800 calories for remission of diabetes، 1500 calories، 1200 calories. في عدد الكالوريز حسب السوق بتاع المشكلة الحاصل للزول وحسب الوزن بتاعه وحسب قدرته هو على تناول الأكل وكده. It's a whole science, but hopefully this is kind of an overview of what do you say. 50% vegetables, 25% whole grain, and 25% lean protein, and less than the total caloric needs, with maintaining physical activity that someone can actually maintain and adhere to, and using the local diet, using the personal preferences. عشان ما نقول له وكل مثلا الحاجة الفلانية الفلانية وهو أصلا ما بياكل، حياكل يومين ثلاثة ويزهق منها ويخليها. So you need a long-term plan, because this is not something that you do one day and and that's it. No, it's a lifestyle. It's changing the whole life style. Next, please.
Before we move to the next slide, هو عندنا سؤال في الشات and I think I was thinking of the same thing، إنه أنت قلت إنه يعني people should stay away من الزلابية والطحنية والأشياء. طبعا كده ما خليتي حالي في الدايت السوداني ما ذكرتيها.
لا
we have a
هو
question.
ايوه اوكي. يعني قصدك نو جوي لايف. انا عندي هنا البيشن حقني بقول لهم يعني والله انت مثلا يعني بتشرب سجاير، يعني ليه بتشرب سجاير؟ بقول لك دي الجوي الوحيده في الحياه يعني حقتي، انا ما بشرب كحول، ما بطلع من البيت، ما بشرب. ففي السودان يعني عندي
الاسكيب حقتنا
escapism to food يعني. يعني I think it's all about the portion control and portion size. يعني ما بنقول يعني للزول ما تاكل. هو دائما what you try to do is something else, a different strategy. حنتكلم عنها فرح يمكن بعدين في البرزنتيشن حقته. How do you deal with the thing on the ground؟ يعني كيف تقول للزول. لكن generally الحاجات البروسيس، الحاجة معمولة في مصنع دي، سواء كان عصير أو فيزي درينك أو كيكة جاهزة أو أي حاجة، بعد ذاك حسي في كثير من الوصفات الزول ممكن نلقاها بسهولة، ممكن تعمل لك نفس الطعم أو أقرب له، ما بنفس كمية الكالوريز وكمية السكريات، في معوضات للسكر وكذا. لكن طبعا في حاجات كثيرة ممكن ما تكون متاحة بسبب لكن حتى الطحنية عملوا منها وحدات يعني sweeteners يعني إذا الزول هنا. يعني I think there is a way forward. حتى مع الدايت حقتنا I think our original diet حقت حبوباتنا وإجدادنا is the best، لأنه ما كان عندهم البروسيسنج of food. البروسيسنج ده ما في، الدقيق الأبيض ما في، بياكلوا الحاجات الفروت اللي بياكلوها، الحاجات الفواكه الطبيعية، الفول حقنا، يعني أكلنا الدخون شنو. فيعني I think that's the answer. So it's no joy in food, but how do we change the food? How do we change the portions of the food? And how do we change the lifestyle to kind of fit in the prevention? And it's very important for people with prediabetes.
And I
تمام.
think that does speak to some of the parts that the question was asking about. هي السؤال من دكتورة شهد صلاح قالت إنه don't you think maintaining and updating someone's diet is hard? So because it's more of a lifestyle وتعويد الحكاية دي, and the economic factors would be take play as well. So how would we be able to change someone's lifestyle despite الحاجات الأساسية دي؟
I think you may correct me if I'm wrong. إحنا مثلا عندنا هنا الأكل المعلب والفروزن أرخص من الأكل الفريش والجاهز، يعني سواء الفريش والصحي يعني. فهنا إحنا بالنسبة إذا نارجمنت سواء كانت في السودان أو في الدول الغربية، لأنه the whole world is facing an economic crisis. It's not unique. Obviously, so you know, we struggle in Sudan more than you know other parts of the world. وفي ناس أسوأ مننا في شعوب تانية. But and that's why it's personalized. That's why it's personalized. يعني أنت أنا ما حاجة أقول لزول يعني أمشي جيب عيش من المخبز التركي في هنا العيش بتاع سكري من المخبز التركي الفلاني، لا، أنت تشوف يعني بتعاين لزول هو بياكل شنو والحياة اللي بفضلها شنو، within you make the change within their preference and within their economic abilities. في إحنا مثلا عندنا في السودان الناس اللي بتعمل شنو موية الفول العدس، يعني في حاجات كثيرة بالمناسبة في أكلنا is good for blood sugar. يعني الفول ده أعظم حاجة حصلت يعني في الدايت، يعني it's very good. هنا عندنا الخواجات بياكلوا baked beans اللي هو الفاصوليا المعلبة دي. الفاصوليا المعلبة دي أول حاجة في علبة بروسيس بيكون فيها سكر ضايفينه بيكون شنو. إحنا الفول حقنا ما في ولا الكلام ده كله is protein happy days يعني. لكن لو أكلته ب5 عيشات يا هذه المشكلة. ف I think you just work with the individuals بميزانيتهم بحاجاتهم المتوفرة لهم بالabilities حقتهم. That's why there's no one size fits all. There's no diet that fits everybody. الحاجة المهمة الثانية إنه the person has to be ready for change. You know, all of us in any stage of our lives, sometimes we're not ready for change. يعني. So it's important also to understand is the individual ready for change؟ لأنه ما أعرف إذا مر عليكم الموتيفيشنال الstages تحت الموتيفيشن. So if a person is not even thinking about change, you really need to help them move to that part first before going on to give them a diet prescription. But if someone is really motivated, they will do it. يعني I've had people who have been on insulin with very high HbA1cs and they've reversed their diabetes altogether. Why? Because they were motivated. So motivation is the key. Once you get them motivated and get them to understand why they need it and why they want to do it, and they want to do it themselves, then the change can happen.
Okay, thank you. And I hope that does answer Suad Shahid. I'd also like to add that we have about 2 minutes left for your presentation.
Good, not much to go. So these are the physical activity guidance. 150 minutes of intensive physical activity in a week, or a mixture of both. You're welcome, Shahad. لازم يكون منها strengthening activity، يعني حاجات زي مثلا رفع حاجات ثقيلة، تطلع وتنزل سلم، يعني حاجات بتقوي العضلات دي on 2 days and reduce extend period of sitting. أنا حسي عاملة البرزنتيشن حقتي دي وخدت لي كمية من الحاجات وواقفة والكمبيوتر بتاعي at my level. In my office there is like I have a standing desk، مش standing desk يعني اللي بيشتروه الغالي ده بتاع امازون، لا، خدت لي كراتين وحاجات ولما اكون زهقت من القعده بقيف. ف it's about انا عندي كمان السكرتير حقتي. I'll see if I can share her story somewhere, maybe on Twitter or because she's very happy to share her story. سكرتيرة نزلت وزنها، عامله لنا حسي غلبه لانه هي بتعمل حاجه اسمها كتل اكسرسايز. in the UK they love the tea، يحبوا الشاي الشديد، وكل 5 دقائق البريك بتاع الشاي، بس ما عندنا ستات شاي للاسف، يعني لسه ما اكتشفوا الحاجه دي. ف what they do is they go to kettle. فلارا لما تمشي الكتل خدت لنا بوستر كده هي ما قاعده تشتغل. انا الصراحه امشي لي كتل ما قاعده اعمل لي اكسرسايز ولا احس انه بتمشي الكتل عندها اكسرسايز تحت الكتل يعني عندها بوستر خدتها لنا كبير كده and she works during that time في الكتل بتاعها. تخدها تغلي في النار مسافه ال5 دقائق او اقل من 5 دقائق، غلت كبت شاي وشالته ومشت رجعت لشغلها. ف it's just about how do you put that into your daily routine as much as possible. تمام. next please. عشان الدقيقتين أنا I think that's it bang on. يدينا وقت ناخد أسئلة وبعد ذاك نشوف presentation بتاعت دكتور فرح.
Yeah, thank you so much, Dr. Mona. I personally enjoyed that shit, and I can see that the audience enjoyed it برضه. إذا في زول عنده أي سؤال, you can feel free to raise your hand. بس ممكن تكتبوه في الchat. We're going to give you about 2 minutes كده, and then we'll move on to our case presentation. في الدقيقتين دول بس I'd like to go through a quick reminder كده معاكم إنه السيشنز دي هي بتتعمل عن طريق الاي ايكو بلاتفورم اللي هو لا محتاجين نسجلوا فيه عشان الاتندنس حقكم will automatically be logged when you عشان بعدين احنا نقدر نرسل لكم السيرتيفيكتس حقت كل سيشن يعني. اضافه لكده نحن عن طريق الموقع برضه بنقدر نرسل لاي زول لانه بيدينا لسته من الناس اللي حضروا بنرسل للناس زي ريكاب ايميل بعد كل سيشن زي ما شايفين هنا بيكون فيه اللينك بتاعت يوتيوب لل ريكوردينج بتاع السيشن والايميلز حقتنا نحن الكوردينيتورز انا ومعي امل وفاطمه والمعلومات عن السيشن الجايه وهكذا يعني. so we would be very grateful يعني اذا ممكن you should sign up عشان بعدك نحن نقدر نرسل لكم الحاجات دي. الحاجه الثانيه الفيدباك بتاع السيشنز because it is a necessity بالنسبه لنا نحن للمونيتورنج and evaluation بتاع السيشنز حقتنا دي. ممكن بس تخش عن طريق دي زي انت دي صوره دي سكرين شوت من الموقع في ذات نفسه. بتخش الاسم بتاع السيشن you can just click submit feedback هناك and it will it's just form فيه زي 15 سؤال كده وبياخد منك مثلا كتير ان شاء الله. Okay, and if we have no questions then we'll be moving on to the case. Okay, sorry. Last thing انه لما تخشوا للسيشن feedback form تأكد انه اللوجوز حقتنا دي هي قاعده فوق just to make sure they're on the right form ان شاء الله. طيب الكيس برزنتيشن لسه حقتنا حيقدمها دكتور فرح. Before that, sorry, one last thing. دكتورة منى القصة بتاعت your secretary, if she does post it on Twitter, you could send me the link and then I can send it to everyone in the recap email إن شاء الله يعني ما بكون في مشكلة. Okay, perfect. Okay, Farah, are you with us?
Is my voice clear?
Very clear. Take it away.
Okay, Assalamu alaikum. I'm Farah Saifuddin. I'm a fourth year medical student. First of all, I would like to welcome you all for attending our session, and I hope you're having a good time so far. Me personally, I'm having a really good time. Thanks to you, Dr. Muna. I'll be presenting the case for today. So let's start. Okay, a 35 years old mother of 4 complains of discoloration on the back of her neck. She also says she feels tired most of the time and that this has been worse during the past 5 months. On examination, there is an area of rough, hyperpigmented skin on the back of her neck with multiple skin tags. Her BMI is 30, and when asked about diabetes, she mentions that during her last pregnancy, her doctor mentioned something about intolerance to sugar and that they gave her pills for it. Saying something similar happened to her mother many years back, but doesn't remember much else. Her child was born light for dates, and when checked, her HbA1c was 6.1. كلكم فهمتوا الكيس. طيب هنعمل quick recap for the cardinal points regarding our case. 35 years old age, multigravida, feeling tired most of the time, acanthosis nigricans, which is the skin pigment discoloration on her neck, a history of large for dates, BMI 30, which is considered class 1 obesity, HbA1c as 6.1. As you can see, this is a multifactorial problem, and in the next couple of minutes, we'll be discussing the risk factors, the management and effective counseling techniques for our patient. Let's jump to the first question. Okay, this is an open space for discussion. I'm going to be asking the question, and I'll leave the mic for you, or whoever wants to say something. Okay, the first question is, what indicators in the patient's past history points toward her potentially developing prediabetes? السؤال لكم اللي قاعدين في القاعة وبرضه الناس اللي قاعدين يحضروا بزوم. الحاجات اللي في التاريخ المرضي بتاع عيانتنا دي اللي بيخليك تفكر انه هي اللي ادت للبري دايابيتس شنو؟ اوكي تفضلي. Class 1 obesity, yeah, perfect. هي obese في الحالة دي ممكن تكون predisposing ل developing prediabetes and diabetes. Thank you. تفضلي. When she was pregnant, she had intolerance to sugar. Yes.
Farah, could you switch the microphones because we can't really hear the audience very well.
Okay,
Also, in the meantime, you can also add your answers in the chat. I see we have an answer already right now. Dr. Nahid says obesity. Yes, that is very correct. You can add your answers in the chat, or you can raise up your hand to answer and unmute yourself. Fatima says family history, and that's family history of probably going to be gestational diabetes. That is correct. Okay.
Okay, does anyone have any other opinion? So the chat. Nothing good with June as Fatima. Diabetes during pregnancy. Okay, back to you, Dr. Muna.
Back to you, Dr. Muna.
Yeah, thank you.
Something.
Thank you. Yes. Thank you for the presentation. So really, what you do when you analyze a problem, it's a word-by-word analysis. So 35. So remember when we spoke about the age, and so obviously she's young, so age is not a risk factor here. Discoloration. So this is a feature that acanthosis nigricans. And so you take it sentence by sentence. BMI, see if you've correctly, as you know, in the chat and the audience identified obesity as a risk factor, gestational diabetes, family history of diabetes, and I don't know if somebody has mentioned that the large 4-date baby is another one. I don't know if it's been answered, but that's also one of the pointers. So when you have a problem, you just go sentence by sentence and try to identify, because usually everything that's mentioned there means something, whether it's in your exam or in a in a scenario. Yeah, thank you.
Thank you so much, Dr. Muna. Let's jump to the second question. The patient exclaims, but this is a lifetime disease, I can't have it. When spoken to about the possibility of prediabetes and its progression to diabetes, how can she be counseled and what preventive measures should she take? Obviously, she's in denial. She says that diabetes is a lifetime disease and I can't have it. So how will you approach this patient in terms of counseling?
And I believe that this is the hardest part of this case. الكلام مع أهلنا في السودان إنه يقول لك يا أخي لا أنا ما حيجيني، أنا ما عارف، عندي وضع عمي قالوا له حيجيك سكري، لكن هذاك حايم نصيح ما عنده حاجة. It's something that's very common. How would you approach this kind of patient؟ لأنه بلاقونا كتار شديد.
Anything?
Any volunteers from the audience or on Zoom?
عن طريق انه ممكن اعلم بالمخاطر اللي ممكن تقابله بعد ما يتصاب بالدايابيتس، وانه ممكن لا قدر الله اذا انصاب وتجاهل الموضوع ده ممكن يتطور لحاجه اكبر واكبر الين ما يبقى جزء من اطرافه وبعد شويه يبدا مشاكل ثانيه وكذا، يعني ممكن تؤدي بحياته كمان.
Yeah, that's perfect. Like توري العيان الكومبليكيشن
بتاعت المرض حتخليها to get scared اللي هي هتكون حاجة كويسة because if she feels scared then she will follow like healthy lifestyle. And Ahmed,
I think she's already scared that she has a disease that's going to affect her during her lifetime. First of all, I will tell her that it is manageable. She still hasn't reached a critical state, and it's easy. We have, I will explain to her that we have had a lot of cases who had similar cases, but they were able to control it. And I will show her the measures that they are not really like major measures that she needs to take, like small diet changes, some practicing here and there, some exercise. So I will calm her down that she's still like in the safe area, and the process isn't really that hard, and she can do it.
That's excellent.
thank you so much.
Okay, if I can jump in, I think that's really good because we should first of all normalize having diabetes. Like I think we should actually consider telling her that the disease is normal to have and it's really not that big of a deal, and it's something that you can actually live with. And a lot of people actually live with it without any major complications and major changes in life. It's just being more healthy.
Thank you so much, Mohab. Does anyone have any input or opinion or something?
Well, I think we have an answer in the chat.
I think the first thing we should do is assess her knowledge about diabetes and know what she knows about it. That's excellent, Fatma. First of all, we need to know her educational levels and know what she knows about diabetes to elaborate more about the disease to her. That's excellent. Thank you. Reassurance, Fatma Ahmed says. Yes, reassurance is very important in our case because she is in denial and we need to make her feel that it's okay to have diabetes and you can live a healthy lifestyle with it if you stick to a healthy diet and exercise. So reassurance is very important. Thank you, Fatma. Does anyone have anything to say? Okay. I think the proper way to approach our patient is, first of all, we need to make sure that she's comfortable because this is a life-changing news for her, developing pre-diabetes and possibility of developing diabetes. So we need to make sure that she's comfortable, and we need to ask her if she wants one of her relative or kids or husband to be with her. And after that, we need to teach her about the disease itself, the pathophysiology, signs and symptoms, and the complications for the disease, because she needs to be aware of them. And after that, we will show her the management steps, the diet and exercise, and how to stick to a healthy lifestyle. And after that, me personally, I will make sure that she memorizes everything. And I'll inform her about the importance of keeping in touch with the doctor and follow up, because she needs to get tested every month for random blood glucose, and every 3 months she has to take hemoglobin A1C test, and annually she needs to check for complications for diabetes, like doing a renal function test and looking for retinopathy, complications of diabetes, and so back to you, Dr. Muna. What is your opinion on this question? Okay, Fatma says something. Remember, guys, you can always stop. Oh, okay, this is not. Back to you, Dr. Muna.
اوكي بس معلش ادوني 1 second.
Okay, اتفضلي.
And while Dr. Miller comes back, أنا أعتقد إنك ما خليت حاجة في الموضوع ده يا فرح. يعني بداية من الموضوع بتاع finding out more about the problem and then talking about prevention and then حتى stressing الحتة بتاعت الفولو اب دي، لأنه نحن بالذات عندنا مشكلة في السودان بتاعت الفولو اب، إنه البيشنت بيجيك بيقابلك في العيادة بيقول له تعال لي بعد أسبوعين أو 3 أسابيع وما بتشوفه تاني. ف follow up is really important. Another thing I'd like to add إنه scare tactics، الفكرة بتاعت إنه نحاول نخوفهم دي، it's something بتنفع مع ناس فعلا. هي بتنفع الناس اللي بتنفع معاهم شيء. الزول بيخاف من الحته بتاعت البتر والحياه دي، بيخافوا بيسمع الكلام منها. لكن في ناس منهم يعني لما نسمع الموضوع بتاع البتر وكده تاني ممكن يراجع كله. ف be careful with using الحته بتاع scare tactics دي مع البيشنتس، لانه في واحدين منهم they could be turned off there. but اذا حاسين انه التاكتيك دي حتنفع مع البيشنت ده من الانتراكشن you should go ahead with it. yes. and back to you Dr. Mani.
انا شايف انه انت تربطها بانه لو ما اكلت اكل صحي، لو ما اخذت الادويه بتاعتك، هو حتصل المرحله بتاعت البتر، فانت تكون مربوطه بانه يهمل في المحافظه على المرض بتاعه. يعني تخليها طوالي مربوطه بانه لو ما عملت كده حيحصل لك كده they won't get scared.
correct. yeah. and بس هي في الحته دي الزول المفروض يخليها لقدام شويه في الدسكشن، يعني كده ما بتبدا الدسكشن مع زول انه والله يا اخي كم ما عملت كده حنقطع عليك وراك يوم من الايام وحاجه.
Okay, if
Okay.
I can jump in. طيب يا شباب، اي زول ما مسجل في الويب سايت، في زول لسه هنا مسجل في الويب سايت بتاع ايكو. طيب هتعلم انه طيب كده raise hand عشان نشوفكم. 1 2 5 6 7 8. طيب خلاص المسجلين خليكم بعد السيشن قاعدين عشان نسجل لكم هسه وطوالي نسجل لكم حضور. المسجلين وما اخذوا اتندنس قبل برضو خليكم قاعدين عشان ندخل لكم حضور طوالي. ثانك يو.
yeah. and شكرا لك يا مهو. وبرضه اذا في ناس حسيتهم طلعوا ممكن تاخد الايميل حقهم يعني. sorry for the interruption. اتفضل يا دكتور منى.
لا ما في مشكلة. كنت عايزة الدكتور اللي كان لابس بلو تي شيرت اللي كان قاعد يجاوب، كنت عايزة أزرزر شوية لكن قفلت يعني شكله. لكن أو يكون قاعد بالجنب.
قاعد طبعا
قاعد. خلاص أرجع طيب. Not really. So I just wanted to kind of ask, do you know the method that you described in your answer, which was very good? What is it called when you try to get the person to understand what's going to be better in the future? How is the patient's or the person's life is going to be better by preventing diabetes and progress of pre-diabetes to diabetes? Do you know what is that method called? This is a method where there's lots of books and studies and literature that talks about it. Yes, that answer from Fatma. Was that you're answering all the questions? Are you a senior by any chance? If you're medical students, well done. But maybe you're a senior. So yes, it's motivational interviewing. So motivational interviewing is what you use. شفت يا دوب رجعت قدام الشاشة عشان بعد ما أنا قلت خلاص الإجابة حصلت. So motivational interviewing. أحمد خالد. أنا ما أعرف أكيد أحمد خالد. طيب معلش تشرفنا يا أحمد. Next time we'll meet face to face إن شاء الله virtually في next presentation. I think you're one of the coordinators. صح كده ولا لا؟ ولا أنا غلطانة؟ ولا you're yep. Okay, good. طيب عشان كده الأنسر بتاعتك كانت كويسة. يعني you have that advantage, don't you? Yes. So I'm glad إنه يعني الدكتورة على الشاشة من الجهة الثانية ذكرت إنه we need to make them aware of the complications, because this is a school of thought. Some people think let's talk about renal failure, let's talk about amputation, let's talk about this. But the evidence is that these people may not come back, or even if they make changes, they are not going to be sustainable changes. So what you need to do is motivational interviewing. So clearly, as Dr. Farah has said earlier, this patient is not accepting and not showing signs that she's ready. So there was very good comments earlier in the chat about asking her about what does she know, because unless you know about the barriers and the preconceptions, you won't be able to address them. فاول حاجه هي اول ما قالت لي لا حول ده كله يعني حقعد عمري كله الباقي اقوم اعمل فحوصات وشنو كده، اقوم اقول لها طيب انت يعني فهمك شنو عن السكري؟ تقوم تقول لك والله جارتنا ست البنات جاها سكري وعمل لها ما بعرف شنو ومشط الخرطوم وقعدت 8 شهور وجابوها راجعة بالكرسي، وبعد ذاك يعني بتلقى كل زول عندهم their personal story which they perceive as a generalized يعني concept عن السكري. كل زول عنده personal story about diabetes. Whether it's from the media, whether it's from family experiences, whether it's from other يعني aspects of life. So you really need to find what is diabetes for Fatima, what is pre-diabetes. Now, I just want to quickly touch on one thing. So remember that HB1C, she is pre-diabetes, so she needs motivational interviewing, obviously. I need to tell her how her life is going to be better. I need to find out, again, digging back to the history again, is she planning to have a future baby? Because she's 35, still within the reproductive age. And so is she planning to have another baby? Because I may ask, how did your pregnancy go? تقوم تقول لي والله ولدت تعبت شديد في الولادة، ولدي كان كبير وعذبني ودخلوني المستشفى ودوني دم وما بعرف الدايات كانوا هنا شاكلوني في هنا يعني كده. فانت بتلقى انه في personal experience she might not be keen to repeat it again. فانت you look for gains, personal gains for the patient or for the individual. تفتش هي عايزه شنو، هو انت ممكن تقدمه لها عن طريق البيتا دايت and lifestyle. not just tell her انه حتبقي يعني حيحصل لك كده وحيحصل لك كده. She's probably scared of that anyway. She might be aware of that anyway, because who doesn't know that diabetes can cause amputations? Who doesn't know that diabetes can lead to renal failure? They know that. So عشان كده احنا we use a method called motivational interviewing. By the time you are practicing, you really need to nail these techniques. You really need to be aware. So your mission today is to go back and read about motivational interviewing and how you deliver that. I'll look in my kind of files and things that I can see if I can send something to Mushtaba in terms of literature and links. But yeah, so this lady is 35. She might be planning another pregnancy. She has acanthosis nigricans. So I'm just going to go through the case just to cover all the bits and bobs that I have to add to the excellent presentation. So you really don't assume that this is just diabetes, pre-diabetes, because this change, this clinical sign can be associated with malignancies and various other things. Most likely in someone of her age, not presenting with other symptoms, it might just be pre-diabetes. But really as a clinician, because you just don't, ما بتمشي بتقول العيان عنده pre-diabetes, let's focus on that, forget everything else. No. So you need to make sure that this is actually just that and not a malignancy that's causing. So it's not acute, it's not new, there's no weight loss, there's no other symptoms. Obviously ask about symptoms of diabetes as well. بتسأل برضو من وزينة، ما احنا في السودان بيقول لك الزول ده صحته سمحة as يعني the other way of saying overweight or obese. فممكن تكون هي very happy with the BMI, so why not يعني بالذات ثقافتنا احنا في السودان يعني لانه افتكر عندنا جذور قديمه شديد من زمن مجاعه سنه 6 وانه الناس اللي كانوا very skinny هم الناس اللي did not survive، وانه الناس اللي عندها قروش هي كان buy الفودز that are more processed food اللي كان put weight on them وكده. في عندنا ارتباط بالفقر، الفقر بالnormal healthy weight يعني إلى حد ما. مع التعليم وكده الحاجات دي زالت، لكن there's still misconceptions. لسه بنقول الزول ده صحته كويسة والولد ده صحته كويسة، الشافع على البيبي الصغير وعليه يعني ما شاء الله عليه وما بيتشال من الواطة وكده. الناس all unhealthy. صح ولا ما صح يا جماعة؟ يعني احنا نعرف هي ذاتها ممكن تكون مبسوطه بالبي ام اي، حاسه ما عارفه البي ام اي ذاته شنو، بتكون عارفه الوزن، ممكن تكون في حياتها ما شافت لها ميزان. فاحنا عشان ما نكون بنغرد خارج السرب، يعني انت you talk to the patient in their language, in their context, in their environment، تعرف هم فكرتهم شنو، حتى بعد ذاك انت تقول يعني ده مسج. وبعدين كان قلت للزوري لك بتتقطع، بيخد عليك بصر عليك كده بعد 30 40 50 سنه لما يجي يشوف الدايبيتولوجيست بتاعه ولا الدكتور بتاعه يقول لي في دكتور زمان كان شفته في المركز الفلاني يوم كده الساعه كده قال لي لك حتتقطع، وهذه الحمد لله ما حصل لي حاجه. فمرات النيجاتيف مسجز دي will stick but in the very wrong way. يعني حيكون مدى الزمن العيان ده حيتذكرك بالحاجه دي وحيربطك بها، وبيكون في a lot of negativity and negative feelings around it. So just be aware of that. طيب gestational diabetes and pregnancy obviously risk factor. يا هو أنا زي ما قلت لكم الكلام اللي قلته إنه how to tease out حصل لي شنو في السكر. يمكن تكون أخذت إنسولين أثناء الهنا وبتفتكر إنه حسي لو عندها بري دايابيتس حنديها إنسولين، تكون دي الحالة الوحيدة الأساسية المخوفاها من الحقن والطعام والإنسولين القاطع في البلد وكده. تقول لك ولدي كان كبير، مثلا وزنه كبير، أخوانه التانيين كيف، لو عنده أخوان كده. بعد كده بتقوم بتشوف إنه ال HbA1c. So when checked HbA1c was 6.1, so this is in the pre-diabetes stage. فبس عايزة بس حاجة بسيطة أصححها إنه if someone has pre-diabetes they really don't need to go through the routine check of HbA1c وال more frequent testing of the renal function وال urine albumin creatinine ratio والحاجات دي، لأنه يعني that's for diabetes. Type 2 diabetes or type 1 or other types of diabetes, they don't have that intensive monitoring. ممكن ده يكون الموتيفيشن بالنسبة لبعض العيانين يعني نعملها حسي علشان hopefully in the future you will have an independent, healthy life, enjoy your children. يعني الزول ذاته تعرف هو تقول له انت عايز تعملي شنو، تقول لك والله احنا دارنا مثلا نشتري لنا حواشه في الحته الفلانيه، دارين نزرع، نشارك هنا، انا بمشي الحواشه بزرع مع مثلا ناس البيت مع زوجي كده، المشوار اللي بتمشيه قدر كم، يلا طيب كونك انك تتحكمي في السكري او تمنع السكري في المستقبل بيخليك انك تمشي مسافات طويله بدون ما تتألمي، بدون ما يحصل لك اي مشاكل، ما حيأثر، بالعكس بتكوني ولا منتجه زي ما انت عايزه بعد 10 سنين عايزه، يعني هكذا. you take the patient story وبعدين تقوم توريهم انه هم الفائده حترجع ليهم هم بالتحديد كيف. يعني من ناحيه في لما تستخدم motivation interviewing. And I think that's it from me, unless somebody else has another question. شكرا. Yes, it is a fine art. It is indeed. And then you continue to improve your skills as you go. You continue to. So it's kind of, as we all are forever learners. If you're in medicine, you're forever learners. So, and maybe in years to come, the whole concept will change again. There'll be newer techniques. There'll be newer ways of delivering. ممكن يكون في robotic, motivational interviewing techniques. Well, AI-based models. So حيجيكم زمن غير الزمن يعني when you're more senior. So there'll be more to come. It can only get better. So. Just use what the evidence says now and keep an open mind for things to change in the future.
Okay, thank you so much, Dr. Mona, على الsummary that, and thank you for summarizing all of the important points in the case. I'm going to apologize that I'm going to have to move on بسبب الزمن. احنا الناس يسعدني انهم معنا في القاعة لنا حوالي ساعة ونص but I'm sure they have enjoyed it. معلش بس في خطأ صغير هنا في السلايد ده، seem to have forgotten to change it، إنه نحن السيشن الجاي حقنا حيكون about general endemic disease control، حيكون مع دكتور تريني ماثيو من جامعة نبراسكا إن شاء الله. And another thing that I'd like to touch on is إنه إذا عندكم أي أسئلة ممكن you can reach out to us. Sorry, السيشن برضه حيكون حيكون on the 17th يوم 17-12 نفس الزمن في نفس القاعة، and you can also join online. بالنسبة للكلام اللي قاله مهاب قبل الناس اللي ما مسجلين في الموقع أو ما عملوا ساين إن عن طريق الموقع just please hang back زي 5 دقائق كده عشان نسجلكم عشان الريكاب والسيرتيفيكيتس والشهادات والحاجات دي كلها حتجيكم إن شاء الله. And also أنا I believe إنه نحن إذا في يزور عنده أي أسئلة أو لقيتوا حاجة في خلال الأسبوع أسبوعين الجاية regarding السيشن ده ممكن ترسلوها لي أنا أو فاطمة أو أمل في الإيميلات حقتنا قدامكم دي and نحن ممكن نرسل لدكتور منى ونزعج إن شاء الله آخر الليل ده تقوم تجاوبوا ونرد عليكم.
يلا any time ما في مشكلة.
يديك العافية. Thank you so much.
Welcome.
And دكتور منى برضه
ممكن أمل حسن بعدين أوف عشان ما أزرزرك بعدين زي أحمد خالد ولازم أكون شايفاكي ما أعتبرك لما أشوفك تكوني ستودنت فبعدين قوي ينادي أمي ولا أي حاجة ويتوكي يعني.
Alright, thank you. وزي ما قلت شكرا لكم كثير على انضمامكم لنا. It's been a pleasure having you. شكرا كثير لك يا دكتورة منى. The session was amazing and very interactive and we learned a lot and enjoyed it so much. Thank you so much.
Thank you all. Thank you all.
And also I would like to speak on behalf of the attendees from University of Jazeera Hub. We have enjoyed the session very much. It was more than amazing. Thank you so much, Dr. Muna. Everyone is so happy here. Thank you so much.
You were more than welcome. Thank you all. Thank you for attending. And thanks for everyone who is on Zoom and keeping up with the internet connections and all the inconveniences. Yeah, شكرا جزيلا.
Thank you. Okay, so now everyone who is not who has already signed up, you can please يعني you're free to go. خلاص نحن هنعتقكم بعد ده. دكتورة منى also you can feel free to leave. We're going to reach out to you regarding السيشن بتاعت الفيز الجاي إن شاء الله, which will probably be within January or February. Thank you so much. الناس الباقيين you can stay وبس 5 دقائق كده عشان نعمل الموضوع بتاع التسجيل ده and then we'll also let you go إن شاء الله. And thank you so much.
اوكي طيب اول حاجه الناس طيب الناس